So these are the objectives for this presentation. Like I said initially, epidemiological data or key facts, United States Department of Defense, that is USDOD, Patient Safety Program, main functional areas, USDOD Patient Safety Mission and Vision Statements, practicing and maintaining patient safety across the care continuum, promoting a culture of safety and teamwork, parentheses, just culture and HROs, that is high reliability organizations, patient safety events and causes of errors. We're going to look at that. There's something called JPSR, which is a tool to report events, patient safety events, Joint Patient Safety Reporting. That's what it stands for. I believe you're all familiar with the Joint Commission globally. Every year they come out with NPSG, National Patient Safety Goals, and there are some supplements I'm going to add to this presentation if time permits. These are some key epidemiological data I'd like to go over with you quickly. 1 in every 10 patients is harmed in healthcare, and over 3 million deaths occur annually as a result of unsafe care. That is quite phenomenal. 3 million deaths every year because of unsafe care to patients. Here's what we're going to look at. Anybody can become a patient. What would you like to happen to you if you have to receive care in an hospital, primary care setting, or wherever you find yourself? Let's think about this for a little bit. In low to middle income countries, as many as 4 in 100 people die from unsafe care. It's very much shocking to everybody in this audience that despite the fact that we live in the West, America, UK, wherever it is, we're still dealing with patient care issues, patient safety issues. Now imagine what is going to happen in, I'm sorry to use this word, third world economies, like Nigeria and some other countries across the globe, where they are not as sophisticated as the Western world. Over 50% of harm, 1 in every 20 patients, is preventable. And half of this avoidable harm is attributable to medications. Whether over-the-counter medications or prescription medications, they are playing a very huge role in terms of causing patient harm. Some estimates suggest that as many as 4 in 10 patients are harmed in both primary and ambulatory care settings, while up to 80% of this harm could have been completely avoided if certain things are put in place. Common adverse events that may result in avoidable patient harm include medication errors, like I said initially, unsafe surgical procedures, very common, healthcare-associated infections, HAIs, diagnostic errors, patient falls, suicide, pressure ulcers, patient misidentification, unsafe blood transfusion, and venous thromboembolism. We continue. Patient harm has a huge potential in reducing economic growth by 0.7% every year. That is huge. On a global scale, the indirect cost of harm runs into trillions of US dollars every year. Did I say trillions? Yes, that's quite huge. I can imagine if we pump just $1 trillion into the economy of Nigeria today, what sort of transformation we're going to experience from that investment. But we see how we're spending this money as a result of harm that is going to the patients. However, there's a slight bit of good news. A meaningful investment in reducing patient harm can bring about significant financial savings and, more poignantly, better patient outcomes. In other words, when we just invest a little bit into patient safety initiatives, we're going to decrease the length of stay of patients in the hospital. We're going to decrease the cost of care significantly. And again, we're going to improve the satisfaction level of our healthcare workers, nurses, doctors, what have you. A comprehensive analysis that was conducted by Harvard School of Public Health found that medical liability cost a total of about 2.4% annually in healthcare spending in the United States alone. As of 2008, this is translated to about 56 billion US dollars. I don't know where you're coming from, joining this conference from, but in the United States, we are so litigious. And I can imagine everybody has to carry one form of medical malpractice insurance or the other because we don't want to get sued. Should it be so bad? But again, you need to protect your livelihood. And so we need to look into this implication on healthcare providers as well as the patients. Lastly, any form of proactive patient engagement in terms of patient safety initiatives, no matter how simple it is, has been shown to effectively reduce the burden of harm by up to 15%. That is a huge return on investment. Let me ask you this question, the audience. I've been in this country for a little bit over almost 30 years now. And I realized that in the United States, in my banking experience, there is no single bank that will pay you 15% interest on your savings. Is there anybody in this audience that can get up to 15% on their savings in the bank? I don't think so. So now it tells us that if you can invest just a little bit into improving patient safety, we can actually reduce the burden of harm by up to 15%. That is very, very huge. What then is patient safety? Patient safety is one of the topmost priorities for the DHA. What is DHA? Defense Health Agency. DHA is the organization that streamlines military healthcare system in America. And patient safety means providing ready, reliable care to service members, veterans, that is those who have served, and dependents, no matter the circumstances, anywhere and everywhere. Very straightforward. Ready, reliable care. That means it's very safe, high quality, available everywhere, anywhere to the veterans, service members, and their dependents. Then what is the mission of DHA? Very simple and straightforward. To promote a culture of safety for ending preventable patient harm. One, by engaging, educating, and equipping patient care teams to put evidence-based safe practices in place across the enterprise or the organization. What is the vision of DHA? To support the military mission by building organizational commitment and capacity for implementing and sustaining a culture of safety, thus protecting the health of the patients in our care. These are the four main functional areas of the United States DoD Patient Safety Program. Like I said, the first one is managing patient safety events, supporting a learning organization. 3, fostering a culture of safety. And 4, infection prevention and control. What do we mean by managing patient safety events? Basically, we're trying to eliminate harm through systematic identification, investigation, and mitigation of patient safety events. How about supporting a learning organization? By this, DoD is strengthening systems through the implementation of robust medications and providing education and training to all staff members, thereby promoting concept of high reliability in healthcare system, that is HRO. And by fostering a culture of safety, we're trying to make sure that mistakes are acknowledged, they are not swept under the table, thereby leading to sustainable, positive change, respectful and inclusive behaviors that are quite instinctive and serve as the behavioral norms for the organization. And the physical and psychological safety of patients and the workforces altogether are highly valued and ardently protected. And finally, infection prevention and control. This is a very important part of healthcare safety, or patient safety in healthcare systems. As many of you are aware, there are so many infections that patients acquire in the hospital, what we popularly call nosocomial infections. Talking about MRSAs, VRAs, C. diff, Class Bs, and so forth, and so on. Before we dive into this further, we need to do some sort of risk assessment because we know there's a problem, and that is patient harm or unsafe patient practices. So how do we navigate this terrain? We have to do some risk assessment. There are 3 basic levels of risk assessment methodologies that have been developed. The first one is called PRA, Proactive Risk Assessment. Number 2 is Comprehensive Systematic Analysis, CSA, it has 2 prongs. And number 3 is what we call Root Cause Analysis, RCA. Backing up a little bit, proactive risk assessment are designed to prospectively identify and reduce risk to the safety of patients through a 4-pronged approach. When you say something is proactive, that means you're not waiting on something bad has happened. You want to think ahead to prevent that kind of event from happening. And that's why we're looking at these 4 prongs that are looking to PRA. The first one is you want to select a high-risk process. As an example, TORG You basically focus on surgical infections and things like that, I assume. And we perform a lot of complete surgical procedures today to take care of patients. For example, I remember years ago back in Nigeria when I worked in the OR, we had this patient that came in for prostatectomy. He had BPH, he had bilateral inguinal hernia, and unfortunately, because of cost of care and all those kind of things, the surgical team decided that we're going to take care of all these problems just at one blow once we get into the OR. That was kind of too much on the patients. You will not believe that we ended up doing bilateral herniorrhaphy on this patient, right and left inguinal hernia repair, as well as taking care of his prostate that was enlarged. But unfortunately, I'm sad to tell you this, because the patient cannot bear the stress of these multiple complex procedures, we ended up losing this patient about 14 days post-operatively because of the stress of operation. This kind of a practice would not have happened in a civilized world like America. That's not to say that things don't happen in the West. Don't get me wrong. I'm not trying to bash Nigeria or any part of the world that is developing. I'm just telling you that there are some things that we can look at as high-risk process. We want to identify the likely threats that this patient might be exposed to, and we'll be thinking of what are the likely interventions that will mitigate that kind of threat so that patients do not suffer untold harm. And then number 4 is measuring the intervention. Was it effective or not effective? And after it's been measured, can we sustain this intervention such that we can use it continually to improve patient safety whenever we're undertaking such a high-risk process or procedure to take care of our patients? PRA is a deliberate, facilitated, interdisciplinary process analysis focused on the possible failure points in a high-risk or low-volume facilitative capability. CSA, comprehensive systematic analysis. It's a thorough, credible, and acceptable analysis following a patient safety event that seeks to identify system vulnerabilities so they can either be eliminated or mitigated in a sustainable manner to prevent reoccurrence. When we talk about CSA, we're looking at just like patients have not really suffered any event, but we want to think ahead and see what exactly happened that caused the problem, why they have the patient safety event that they experienced. So this is actually based on the system. It could be the process, maybe in the OR, they did not do proper timeout or checkout or whatever you call it to make sure that we're operating on the right limb, which is supposed to be the right limb and not the left limb. Or we are going to give this patient spinal anesthesia and not intravenous anesthesia, just as an example. So we want to make sure that all those system vulnerabilities are properly taken care of such that we can eliminate such in future situations to prevent reoccurrences. Under CSA, like I said, we have 2 approaches. The first one is HSR. HSR is Healthcare Safety Review, and it identifies systemic factors that can produce error and recommend systems changes that will either reduce error or minimize its impact. Very straightforward. The other one is called CIA, Concise Incident Analysis. This is an abbreviated form of CSA that military treatment facilities, or what we call hospitals in the civilian sector, can use for certain patient safety events, principally in small areas like dental services. Then we talk about root cause analysis. What is root cause analysis? RCA is a process used in identifying the basic or contributing causal factors that underlie variations in performance associated with adverse events or close calls. This requires a specific type of focused review that concentrates primarily on systems processes rather than individual performance. When we do RCAs, we're not looking at individual performance, but we're looking at the system issues that actually led to the error in question and how we can prevent such from happening in the future. What are those things that we can put in place in our systems or processes that will make sure that we are delivering care to the patient in a very safe manner moving forward? I realized again that when I was starting this presentation, I talked about medication as one of the major culprits of most patient safety events in healthcare sectors across the world. And this is why DHA, in its wisdom, has come up with a very important center called Pharmacovigilance Center. And what does this do? What's the vision? The vision of PVC is to be the premier organization for the MHS promoting excellence in medication prescribing practices and reducing preventable adverse drug experiences for all its beneficiaries. And the mission of PVC is to provide data-driven evidence on medication safety, effectiveness, and best prescribing practices that serve as force multipliers, directly contributing to keeping the warfighters and other beneficiaries healthy through policy guidance, strategic communication, and education worldwide. These are the 5 main functions that the PVC executes. 1, they perform research studies on safety and or effectiveness of medications that are widely prescribed, have serious outcomes or impact readiness of our troops. Number 2, serve as authoritative resource for safe medication use, pharmacovigilance, and pharmacoepidemiology, and represent the Department of Defense to national drug safety initiatives. Number 3, identify, analyze, recommend, and provide education on best prescribing practices in active duty and non-active duty beneficiaries, and in pregnant and non-pregnant patients to minimize medication harm and improve outcomes. Number 4, support quality and safety metrics and drug safety studies in collaboration with other MHS and non-MHS organizations. And lastly, PVC functions to develop standardized medication safety surveillance and analytic methods for drug safety issues and develop and maintain the Pharmacovigilance Defense Application System, PVDAS, which is a web-based application, web-based semi-automated surveillance and analytical tool and data match for monitoring medications to ensure patient safety for medication administration and prescription. The slide in front of you is just to show you what happens in the military. Basically, patient safety for us is not only limited to when you're working in the hospital or the MTF. For example, my unit is a reserve unit. When we are not deployed, we are constantly working on initiatives that can enhance patient safety before we go into the theater. So this screen is telling you about joint patient movement system, what we're going to do before we deploy. We go into the theater, that is intra-theater. And then when we're in the theater, we talk about inter-theater. And after we have gone out of the theater, we continue to work on things that happened to make sure that patient is always taken care of safely at every level of care. We call it echelons of care in the military. There's another concept in the military that we call trusted care anywhere and everywhere. What is trusted care? Trusted care focuses on continuous improvement to eliminate harm to our patient by identifying and eliminating risk before it becomes a harmful error. And there are 4 things that are very important to ensure that patients receive trusted care. Leadership engagement. The leaders must actually be engaged effectively to make sure that patients are getting the care they require. Number 2, culture of safety must be very much enhanced. And then there is CPI, is an ongoing process, continuous process improvement. We can never be 100% satisfied in terms of safety initiatives. We want to continually refine and research every initiative that we're putting in place to make sure that patients are safe at every point in time. And whatever we're doing must be centered on the patient. That is patient-centeredness. Why do events occur? The common saying is, to err is human. Human error is sometimes a result of circumstances beyond one's control. And processes that depend on so-called perfect human performance are just inherently flawed. As an example, the fact that somebody has been a nurse for 30 years, they have all these kind of certifications and degrees, do not insulate them from committing error when they are fatigued or when the system is not really working the way it's supposed to work. So there are so many things that can actually cause error and that can lead to major patient safety events. So now we're going to talk about factors leading to patient harm. There are 5 categories of factors that can accentuate or bring about patient harm. The first one is system and organizational. The next one is technological, followed by human factors and behaviors, patient-related factors, and external factors. System and organizational factors are complexity of medical interventions. Like I told you earlier, a complex surgical procedure, inadequate process and procedures, disruptions in workflow and care coordination, resource constraint, inadequate staffing and competency development. I'm sorry again to use this example. When I used to work on medical surgical floor years ago, the ideal patient staffing ratio was supposed to be not more than 5 to 1 nurse. But I'm telling you, there are occasions that we have to take about 8 to 1. That is not safe. That is not ideal. This is in the United States of America. There are other countries that are trying to pattern or model after. Now tell me what happens in Nigeria. About a week ago, I was talking to a very junior colleague of mine that I mentor, asking about the situation where she's working in a very big teaching hospital in Nigeria. I won't mention it because of fear of retribution. You will not believe this, working in a medical surgical floor with 15 patients. There was only 1 nurse take care of 15 patients in Nigeria. Do you think that is safe? That is leaving room for a lot of errors, and patients can be injured. Unfortunately, I'm sorry to say this again, in Nigeria and many other underdeveloped economies across the world, there are so many people that are actually grappling with loss of lives and other events because of inadequate staffing, and there is no recourse for them to seek remedy. I've never heard of anybody suing anybody in Nigeria for medical malpractice. I'm not encouraging that, but I'm just telling you that there should be things in place to address things like system and organizational issues that could have been prevented. For crying out loud, this is year 2024. We're talking about, in a medical surgical ward, we have 15 patients to 1 registered nurse. She has to do admission, blood transfusion, medication administration, evaluation of interventions, and many other things over an 8-hour shift. That is unacceptable. Technological issues related to healthcare information systems like AHR, that is electronic health record or medication administration record, MAR. And misuse of technology, human factors and behaviors. There's always communication breakdown among healthcare workers within healthcare teams and patients and their families. Ineffective teamwork, fatigue, burnout, and cognitive bias. There are patient-related factors as a result of limited or zero health literacy, lack of engagement, and non-adherence to treatment protocols. Let me quickly explain this. We are living in an age of IoT, Internet of Technology, whereby people go to the Internet of Things. They go to the internet to research things about their medications and stuff like that. Unfortunately, there is a ton of disinformation and misinformation on the internet today. So we need to find an outlet whereby patients can be directed or can be steered towards getting information that are going to be considered health literate and safe without going to those disinformed websites where they are being misled. Things like, there are so many things out there today, but for example, vaccination, people have spun out a lot of things to discredit vaccination that has been shown to be very much effective over the years of we've been practicing medicine. Lack of engagement and non-adherence to treatment protocols. There are many times, most of these patients, they will not schedule follow-up appointments to come back to see their doctor, to do lab work and things like that. So we have to do more about this because patients today have a part to play in terms of enhancing their own safety. And lastly, external factors. We're looking at things like absence of policies, outdated policies, inconsistent regulations, economic and financial pressures, and challenges related to natural environments. Quickly, these are some of the patient safety events. No harm events, near miss events, adverse events. For the sake of time, I don't want to go much deeper into this. I'll wait until when you have questions, I can address each of these. Again, we're talking about unsafe/hazardous condition, potentially compensable event, intentional unsafe act, Department of Defense reportable events, and there's something I want to emphasize here quickly, sentinel events. According to Joint Commission, sentinel event is defined as any unanticipated event in the healthcare setting, resulting in death or serious physical or psychological injury to a patient or patients. This is not related to the natural cause of patient's illness. For example, there could be loss of limbs, loss of sight, and so many other things that are totally unrelated to why the patient presented to the hospital to begin with. We use what we call JPSR, like I said initially, to report any kind of event. Joint Patient Safety Reporting, that's what we use in DOD. And I believe today, most civilian sectors, they are using something similar to that as well to report any kind of patient harm or patient-related events. This is a sample of what it looks like on the internet, online. National Patient Safety Goals. For the year 2024, For the year 2024, they still maintain that we have to properly identify patients. In the United States, we use two identifiers. Patient will be asked to either state their name, their date of birth, or their social security number. But basically, there must be two forms of identifiers to correctly identify the patient to make sure that we're not taking the wrong patient to the wrong procedure. Effective communication must be improved. For example, the test results must be, when the lab calls in the result, there are critical values. You want to read back to them and confirm that this actually is belonging to this patient and must be given to the doctor at the right time in a very timely fashion. Medications must be safely labeled to prevent maladministration. And finally, we're talking about use of alarms, essentially in ICU and other areas. Alarms must be functioning properly, they must be audible, and they must be responded to on time to prevent. Otherwise, they are not audible, they are not responded to on time, they are useless. And patient is going to suffer untold harm as a result of lack of adequate response to all these alarms in a timely fashion. Prevention of infection is another thing. Hand hygiene, very important. I remember years ago as a nursing student back in Nigeria, my microbiology professor used to say something to describe sterile objects. It goes like this: sterile objects are like pregnant women. They are either her or they are her. It's that they are pregnant, they are not pregnant. So you want to make sure that the chain of sterility is maintained at every point in time to prevent things like CLABSI, central line associated bloodstream infection, SSI, surgical site infection, methicillin resistant Staphylococcus aureus infection, MRSA, C. diff, and VR infections. Again, I want to quickly say this about antibiotic stewardship. Years ago, when I came to the United States, it was very shocking. I first worked in long-term care environments. Any patient or resident at the time, we call them residents or geriatric patient, whatever. Whenever they kind of train a fever, whether it's low-grade or mild-grade fever, a little bit of cough and some respiratory symptoms or urinary tract symptoms, the next thing the doctor will prescribe is antibiotic therapy. I felt so awkward seeing that, because in Nigeria, where I trained before I came to the United States, before a doctor will prescribe an antibiotic medication for a patient like that, they will have to do what we call culture and sensitivity. Unfortunately, that was not a practice when I first practiced in long-term care in the United States years ago. But over the years, what we saw was there was a resistance of many of these organisms like MRSAs and VRAs. And so there's a change in paradigm towards making sure that we don't use antibiotics indiscriminately like they used to be used years ago. So we're not talking about antibiotics stewardship programs across different healthcare sectors to minimize resistance and to ensure that patients are not having problems they don't have to deal with. Then patient safety risk. Patients have to be assessed for falls, and suicide precaution have to be put in place. And finally, we want to make sure that patients that are going to surgery, they are correctly identified and the site of surgery is properly marked so that we don't operate on the wrong site while the patient is on the operating table. And that is 2024 sample of the 2024 Joint Commission National Patient Safety Goal. It cuts across hospitals, ambulatory care, primary care, and so forth like that. Again, we want to make sure that we build a culture of safety and teamwork. Very importantly, sharing information is key to ensuring that all DOD patients are having one vision for patient safety. And like I said before, you see something, you say something. There's something we call CPG, Clinical Practice Guidelines. Everybody is encouraged to participate. And there must be room for open communication whereby there is problem solving instead of problem blaming. We don't want to blame people for making errors. We are all humans. When mistakes happen, encourage people, empower them so that when they make mistakes, they can voluntarily own up to their medical errors so that we can address the issue and prevent a recurrence of such kind of event in the future. Now, how do we tackle patient safety problem? That's what we call system approach to patient safety. Quickly, ensuring leadership commitment to safety and creation of a culture whereby safety is prioritized. Ensuring a safe working environment and the safety of all procedures and clinical processes. For example, use of timeout in the OR, building competencies of health and care workers, and improving teamwork and communication. For example, to improve communication, some tools have been developed like use of HISBAR. I'm going to talk about that in a little bit. Engaging patients and families in policy development, research, and shared decision-making. Again, today, you want to give patients ownership in their care. Gone were those years that you have to be the one dictating for the patient. But this time and age, to enhance patient safety and to get their buy-in into what we are doing, they have to be empowered to participate in their care. Establishing systems for patient safety incident reporting for learning and continuous improvement processes purposes. Then we move into team steps. What is team steps? Team steps is an acronym that stands for team strategies and tools for performance to enhance performance and patient safety. Team steps is an evidence-based framework to optimize team performance across the healthcare delivery system. Team steps is based on team structure, and 4 teachable, learnable skills are very paramount. Number 1 is communication. Number 2 is leading teams. Number 3, situation monitoring. And finally, mutual support. By communication, we're talking about a structured process by which information is clearly and accurately exchanged among team members. And the commonly adopted tools for this purpose to ensure proper handoff include highest bar, call out, and check back high pass. I'm going to explain that in a little bit. I'm sure many of us would have come across highest bar. Highest bar is the communication tool to ensure patient care is well coordinated when it comes to giving reports from one nurse, for example, to another nurse, from a nurse to a doctor, or whatever have you. High stands for identify. You want to identify who you are. And talk about the patient as well, identify the patient as well, your location, and what you've done for the patient. The situation, what is the presenting problem? What did the patient come to you for? What have you done for the patient? Background, a brief history related to the patient's problem. And then your assessment, vital signs, labs, and what have you that have been taken out, that have been conducted. Everything has to be captured in your assessment. And finally, your recommendation. In connivance or in collaboration with the doctors or other medical care team, what is the plan of care for this patient? That is what's going to come under your recommendation to take care of this patient. And we're talking about high pass. High pass is another good tool that you can use to ensure proper handoff of patients. High is illness severity. You want to tell them whether the patient is stable, unstable, they're still being watched. Patient summary, that is history of the patient illness, what and what you have done for them, the cause of the hospitalization, ongoing assessment, your care plan, and stuff like that. Then A is action list. Is there a to-do list, things that must be done for this patient? Maybe you just give medication for pain. You want to tell them when the patient is going to be due for evaluation of the effect of the medication for pain, whether it's effective or not. Timeline and ownership. S, situation awareness and contingency planning. And finally, the last S is synthesis by the receiver. You want to hear from the recipient of your information whether they got the message as you relate to them to ensure that there is no patient safety event as a result of handoff to this individual. And leading teams, that's the next one. Effective team leaders organize the team. Effective team leaders identify and articulate clear goals. That is, they plan through briefing. They assign tasks and responsibilities based on the skill set of the team members, their experience, and their education. They monitor and modify the plan, and they communicate changes as much as needed through huddle. The plan of care is iterative. In other words, it's subject to revision it's like documents that has to be changed from time to time and must be communicated to the team members. The team's performance must be reviewed, and feedback must be given as needed. Managing and allocating resources effectively is very important for effective leadership. Facilitate information sharing, encourage team members to assist one another, facilitate conflict resolution in a learning environment, and finally, model effective teamwork. That is, you want to evaluate your team. Have we been able to achieve our goals to take care of this patient effectively? Is there anything that we did perfectly that we need to tap ourselves on the back and say, yes, good job? Are there areas of improvement? Are there things that we could have done better? That's what you do when you do debriefing. So this has to be done to make sure that when next to taking care of a patient, areas of improvement will be incorporated to make sure that the patient gets a stellar experience without any risk of being harmed or being injured in the process. Components of situation monitoring and cross-monitoring. Status of the patient, looking about patient history, vital signs, medications, physical exam, plan of care, psychosocial issues. All this must be taken into account to describe the patient. How about the team members? Are they fatigued? Is the workload comparable with their skill set? Is it going to allow them to function effectively? How about the task, the performance and the skill set, as well as the stress on these team members? All these things must be taken into account to make sure that there's no room for any kind of error or patient safety event. How about the environment of care? Is it too warm, too cold? Administrative support, human resources, triage acuity, and equipment availability. These are things that constitute the environment of care that must be taken care of adequately to ensure that patients receive safe care. And how about the progress towards the goal that was set for the patient and the team altogether? Are the plans still appropriate? Do we need to modify the plan, like nursing care plan? And assessment, diagnosis, planning, implementation, and evaluation. You want to go back and reevaluate whether your plan of care is still meeting its objective or is not meeting the objective, so we can reevaluate and come up with another plan of care to make sure that patients are getting safe care at every point in time. Cross-monitoring. This is a harm error reduction strategy that involves monitoring actions of team members, providing a safety net within the team, ensuring that mistakes or oversights are quickly caught and watching each other's back. You want to make sure that you're taking care of yourselves as team members without trying to backstab anyone, because you're not going to get extra credit for making somebody look bad. So you need to watch each other's back for the sake of patient safety. That's very important. This is another checklist that is very important for every team member to be familiar with. It is called safe checklist. Number one, illness. Do I have any illness going on? Any symptoms that will obscure my judgment clinically, that will not allow me to take care of patients safely? Am I on any medications, whether it's prescription or over-the-counter medications? Am I under stress? Family stress, job stress, psychological pressure, what have you? Alcohol. Alcohol is an impairing substance, can impair judgment. Have I been drinking within the last 8 to 24 hours? As a care provider, would you consider it safe to go to the hospital environment to be drinking under the influence of anything whatsoever? Am I fatigued? Am I adequately rested? Many of us are guilty of this. Remember years ago, coming to America, we want to settle down. We want to make sure that we provide for our family. There is pressure back home to support parents and family members. Many of us will work 16 hours, 18 hours. This is not good for us. And many people are still doing that today. Studies have shown that when you are sleep deprived, you are like a drunken sailor. Anything that you do when you are sleep deprived, you can actually commit a lot of medication errors and many other errors that will affect the patient. Is it worth it? When you need to rest, make sure you rest. And eating, finally, am I adequately nourished? Not eating junk food. Again, that's another problem with us in the West. Many of us have no time to really sit down to get well-balanced diet. Instead, we go to drive-thrus. I don't know what in the United States we have, McDonald's and stuff like that. These are not healthy food. They are junk food that will not nourish our body. So we want to make sure that as a person in the healthcare team, you are constantly checking your I am safe checklist to be sure that you are fit to take care of the patient. That's what that is about. The next one is called STOP. Stop, think, act, and review. Stopping means you pause to focus on the immediate tasks given to you. Think methodically and identify correct action that will benefit the patient. Go ahead and perform the act safely and review what you have done. Did you help the patient? Did you solve the problem? Think before you act. Focus. Take a moment to reflect on the intended action, the situation, and the expected outcome. How are we doing on time? Hello?
You can proceed.
Okay.
It's very detailed and we are enjoying that. Thank you.
Thank you so much. Mutual support. Under mutual support, we're talking about task assistance and feedback. Task assistance involves key strategies that include team members protecting each other from work overload situations, effective teams placing offers and requests for assistance in the context of patient safety. We want to be considerate when we are making requests. For example, let's say you have to take off for some reasons. You want to be mindful of your co-workers so that the workload on them will not be too much. I'm not saying you should not take off when you need to take off, but try to balance things out so that it will not be a undue burden on your teammates when you are doing that. And fostering a climate where it's expected that assistance will be actively sought and offered. Nobody should be afraid to ask for assistance. Because when you fail to do that, you make errors. Guess who suffers? The patient. When two elephants fight, it's the grass that suffers. We don't want the patient to suffer. When you need to ask for assistance, do not be afraid. Nobody knows it all. Ask for help, and that will be rendered to you. Feedback. This is information provided to team members for the purpose of improving team performance and should be given timely, respectfully, specific, directed towards improvement, and be very considerate. The last one is advocacy and assertion. We are continually advocates for our patients. And so, as nurses, doctors, surgeons, what have you, we must continually, assertively advocate for our patients to make sure that they get the best of care at every point in time. Now, let's look at just culture and HROs. The number of deaths in the United States related to medical errors remains unacceptably high, complicated by the problem of underreporting due to the fear of the consequences. What is this saying to us? A lot of people will be afraid today to own up to their mistakes, to their errors, because guess what happened years ago? When they report voluntarily, they get penalized. They get reported to the board of nursing. They get suspended. They lose their pay and things like that. So people are afraid to voluntarily report their errors. But we want to shift from that culture to what we call a just culture and not a blaming culture, whereby every team member in the healthcare sector will be empowered to voluntarily report their mistakes and whatever errors they have made without fear of any retribution or any untold consequences. So that's the next point there. A paradigm shift is needed from assigning blame and punishing individuals to such that is trusting and just. Improving patient safety requires that high reliability organizations, HROs, strive to ensure that the culture of the organization is that of trusting and a just one. Healthcare HROs began in 1999, but as 2021, in a British Medical Journal Quality and Safety editorial, HROs in healthcare is still a long way to go. What are the 5 principles of HROs? Sensitivity to operations, that is preserving constant awareness by staff and leaders of the state of systems and processes that affect patient care. Awareness is key to noting risk and preventing harm to the patient. Number 2, reluctance to simplify. Simple processes are good. A number of times we want to make things easy, simple, right? But simplistic explanations for why things work or fail are too risky. Avoidance of overly simple explanations of failure is thus critical. In the name of trying to simplify things, we have to be very careful not to be creating room for making errors that will harm the patient. Number 3, preoccupation with failure. HROs will make us to view areas of safeguards as areas of improvement rather than saying, yes, we're beating our chest, this is good. We have put this as a safeguard in place and then we're able to do. No, rather we should view near misses as proof that the system has effective safeguard, but they should be viewed more as areas of improvement, CPI, continuous process improvement. Deference to expertise. Many of us as leaders, as supervisors, we are arrogant. We think we know everything, but unfortunately, I've learned that you stop learning until when you die. Nobody knows everything, or no matter what your pedigree is, whether you have a PhD, whatever you have, your experience, these are all good things to have. But that does not mean that you are a Mr. Know-all. You do not know everything. So as leaders and supervisors, we need to learn to listen to experts so that when listening to others, other people's opinion, we'll be able to make room for improvement and avoid errors. And lastly, resilience. Leaders and staff need to be trained and prepared to respond adequately and appropriately when system failures occur. These are some of the benefits of HROs: greater staff engagement, collective mindfulness, solutions to complex problems, improved patient safety, quality improvement, more definitive and reliable care, a safer work environment for clinicians, including psychological safety, ability to better manage unexpected events. Now let's quickly look at barcode medication administration, BCMA. BCMA is an inventory control system that utilizes barcodes to prevent human errors in the distribution of prescription medications at medical facilities. The goal of BCMA, which was pioneered by the Veterans Health Administration in the United States, is to make sure that patients are receiving the correct medications at the correct time by electronically validating and documenting medications, employing the 5 rights: right patient, right medication, right time, right dose, and right route, which are all programmed into BCMA. BCMA has actually made it possible over the years for a number of medication errors to have been prevented in healthcare establishments. I want to quickly shout out to some military establishments that received top marks for patient safety in the year 2024. There's a non-profit organization in the US known as Leapfrog Group. Their goal is to improve quality and safe care across the United States of America. On May 1st this year, after assessing more than 30 performance measures at 3,000 medical care centers and hospitals across the country, Leapfrog came out to say that 9 military hospitals, earned grade A, and 9 earned grade B, and 3 earned grade C. And none of these hospitals that are affiliated with the military received the lowest grades D or F. That's kudos to the military treatment hospitals. Again, we talked about patient safety today. I'm so sorry I rushed through some of these things because of limited time. Pardon my speed. And again, to summarize the presentation, there's a parallel between military and civilian healthcare systems whenever we're talking about patient safety. The only distinction is that settings often are different, but core principles of safety align no matter where you find yourself, whether military, whether civilian. We all work together to make sure that patients are taken care of safely, because guess what? Anyone can become a patient. And I want to be treated the way I'm going to treat another person. Thank you very much for listening. Your questions are welcome.
Thank you so much, sir.
You're welcome.
So really, okay. ADK, you can unmute yourself to ask the question. Hello, sir.
Hello, I'm here.
There's a question. Yeah, there's a question here.
Okay.
He greeted you that great overview, encouraging healthcare team members to utilize current research is crucial for implementing best practices.
Yes.
What are your goal to resource for finding research that is peer reviewed yet free to access?
Thank you so much for that question. Actually, we're so blessed in the United States that we have a plethora of resources that can help us towards getting peer-reviewed materials. I'll be willing to share that detail with anyone that is interested, because there are so many of them that you can actually that we can share, that we can explore in terms of looking for materials that will gear you towards safe patient patient safety practices.
Thank you so much, sir.
You're welcome.
Yeah. So I want to ask this question: how can we navigate the situation where the management is about let me call it gain than looking after the staff welfare of that is taking care of the patient, like instead of employing experienced and adequate staff, they try to reduce, and on the long run, there is error from that. So how can we navigate that situation, sir?
Thank you so much for that question. Actually, I'm sorry again to say this. I'm not trying to bash my home country, Nigeria, as an example. That's where I came from. a number of things that are happening in Nigeria today and most other developed, in underdeveloped economies will not happen in the West. For example, I said in my presentation that in the United States, we are so litigious. And I can tell you honestly, as I'm talking to you right now, I work in a federal agency and I'm in the military. We are covered, so to say, in terms of litigation. But despite that, I still carry malpractice insurance. Now, to answer your question, the leaders in such environments, they have to be exposed to some very hard situations whereby they suffer consequences to really appreciate the dangers inherent in their practice, because you should not place profit over the life of patients. Let me give you an example. Where I work here in the United States, anything that is about patient safety, the most junior person in my unit, as a sergeant, can call me to order, even though I'm a lieutenant colonel. And I have no reason to penalize them because that is the culture that we have established here. So that culture of safety has to be embraced, has to be established. Otherwise, we're going to be dealing with this forever. Like I told you in my presentation, I was talking to one of my mentees about a week or 2 weeks ago, like I said. She works in a teaching hospital in Nigeria. I'm not going to mention the state now. One of my bosses is on the line. It's not your state, sir. I'm not talking about UTAC. So, but I'm not going to mention the state. It's very shocking that in 2024, a registered nurse is working in a teaching hospital that should be the model of excellence. A staff nurse to 15 patients, that's unconscionable. That is not good. So I imagine that's happening in a teaching hospital. What will happen in private hospitals? I don't know if you're getting my point. So the culture has to be changed. I don't know what you can do in those places, but like I said, I'm privileged in America that I'm living, or most people in the West, you can't do that. We have unions in place that will even challenge you. They will take you to court, and you have to deal with one single malpractice. You close your business, another hospital will not practice that kind of a thing because nobody wants to lose their business. Does that make sense? Does that answer your question? Yes. So I don't know what those institutions will do in places like Nigeria and other parts of the world that are developing, underdeveloped. They have to learn, and again, we have to be advocates for our patients. Nurses, doctors, we know better. Some of these people in administration, they have no medical knowledge of any kind, but they are just about business. But we are the ones to let them know that, look, this can happen to your patient. A family member of yours can be a patient. That's the golden rule. Remember, those who are medical doctors, Hippocratic oath to practice medicine, do no harm. Florence Nightingale pledge. We took that as nurses. We want to make sure that we put ourselves in the patient's situation. What if were to be my family member, my dad, my brother, my sister? How would I like them to be treated? Until we get to that point, we're going to be beating around the bush. So I'm willing to do whatever I can do to talk to leaders like that. But the point is that we have to do something as advocates for our patients. Government institutions and all that, I don't have any control over that. But the thing is, as nurses, doctors, we can advocate for our patients to make sure that hopefully we change in orientation politically and things like that. There might be some shift to make sure that patients are getting the kind of care they're supposed to get safely when they come to the hospitals like that. That will be my response to that.
Thank you so much, sir.
You're welcome.
Yeah. Is there any other questions? Okay, there's a question, sir. How will you advise an nurse working in an institution where patients are at high risk of developing surgical site infection due to inappropriate infrastructure? And yet, this is beyond his or our control.
Would you like to explain what you mean by inappropriate infrastructure? Because looking at SSI in America, I'm telling you sincerely, there's a lot of studies that have been conducted, and that has been significantly reduced because of things that we put in place. We have CAUDI bundles, Class B bundles, and things like that, things that must be done when we are going to go to the OR. So unless there's a break in those bundles, For example, let's say your sterile equipment pack, there is contamination somewhere along the chain, and nobody discovered that. That would be a point of entry for microbial activity. But if such is not really like that, basically, if the chain is maintained as it should be maintained, there should be no room for exercise, at least in the OR. So you need to check your process to be sure that people are following the processes and doing the right things to make sure that whatever you're put in place to ensure that the environment is infection-free or contagion-free is adhered to. And that will really help us mitigate exercise in the OR settings. But from my experience here, honestly speaking, with all those bundles and things like that, we've been able to contain that, and it's been very successful.
Thank you so much, sir.
You're welcome.
Yeah. Any other questions from the house? I think we have exhausted the question. I will hand over to Mrs. Owokoli.
Thank you so much. Thank you so much, Lieutenant Colonel Dr. Olufemi. Thank you for honoring our invitation. The webinar was actually very insightful. It was really, really detailed. I was trying to capture the screen, but I think I lost a few slides. If you don't mind, can we request for the presentation? You can personalize that if that would be fine, sir.
Oh, I will send the slide to you for distribution for anyone that likes to have it. Thank you.
Okay, thank you so much for that, sir. It was very detailed. I learned a lot personally on the role of pharmacovigilance, on the role of HROs, on the role of CIAs, RCA, the root cause analysis, risk assessments, and more. Those were really, really important and vital in this contemporary society, especially not just the military zones, but every OR needs to have that as well. And as you said, I personally, for myself, I also trained in Nigeria before coming to Ireland, and the difference is massive. The difference is really massive. When I first went into the operating room environment, it was like, no, because I know in Nigeria, for example, we get trained by professors, by surgeons, and more, even consultants. They get to train us and everything. But when someone comes to the advanced environment, discover that those things that you improvise in African low and middle income countries, improvisation is not allowed in the Western world. And as you said, that hospital could be closed. When HIQA comes for a review, when Joint Commission comes to review and some things are missing, they kind of put action plan in place. And if those things are not met within a time frame, there could be a problem, and that facility could actually be closed. So like things that we improvise, there's no improvisation in the Western world. And in the Western areas as well, they've got the diseases and the equipment to treat them, if you understand what I mean. But in African settings, we get to see all those diseases in the books, but we don't really get one-on-one contact with those advanced patient safety equipment and more. Thank you so much for that eye-opening session. I believe that we can bring you back for more with your permission. If that would be okay, sir.
Oh, sure. Actually, I wouldn't mind coming back if you need me. I want to just say something quickly. There's another question in the chat box.
Oh, okay.
What are the measures in place currently to promote self-error report? So actually, I think I addressed that in my presentation. We have to, in the Airforce, we have something we call code of conduct.
Yeah.
Now, integrity first. Service before self, excellence in all that we do. You must have integrity.
Yes.
But the other question is this: everybody wants to take care of their livelihood. You work in an environment whereby you tell on yourself, okay, I made an error. And the next thing is they set up this disciplinary committee. They're going to report to the board of nursing. They suspend your license. You have to go through remediation and things like that. You have to spend money to do all that. And you cannot practice as a nurse until after you've completed all that. How many people will be willing to do that? So that's why we're talking about just culture, to answer the question. Every establishment must work towards establishing a just culture. There's no blame. There's no reproach. In fact, when you do that, people will voluntarily, they will not be afraid. Let me give you an example. Nobody knows it all. Despite my little whatever. I was seeing a patient in my office about 2 months ago. I saw the patient about 8 o'clock in the morning. I needed to do some drug screening on the patient for one of the things I needed to do with this patient. I put in the order to do the drug screening and I asked him to go to the lab to get the result, to get this, to submit the specimen for the testing. He should see me in 30 minutes. By the time he came back to my office in 30, 45 minutes, you will not believe it. I got distracted to taking care of some other things. I thought that I put in the order. When he came back to my office, he said, sir, I'm back. My result is back yet? And normally the result should be back within 20, 25 minutes, 30 minutes at the most. I look in the chart, there was nothing. I called the lab. Hey, what's going on? My patient was with you about 30 minutes ago or whatever, and then the result is not in the system. So, you're kidding me? There's no order.
Wow.
I told the patient, I'm sorry, I'm going to take ownership of this. It's my error.
Yeah.
I told him, I'm sorry to cause this delay. I forgot to put in the order. I said, oh, Femi, and blah, blah. I said, no, okay. And that was it, don't worry about it. I put in the order, they took care of the business. In many other instances, people will not be willing to do that but my environment my workplace encourages that. When you make mistakes, own up to your mistakes.
Yeah.
We don't really want to see that. I believe one thing, no rational nurse or doctor will come to the hospital with a view to injuring a patient.
Absolutely.
We have crazy people, don't get me wrong. We have had cases in America where nurses are deliberately injecting patients insulin doses that are killing patients. Those are animals, they are not human beings. Excuse my French. But a rational nurse or doctor will not wake up one day and say, yes, I'm going to the hospital to kill people. And that's why we are humans. Yeah. We make mistakes. And so to answer the question, the environment of care has to promote just culture. And there are questions about getting the slide. I don't know how you're going to share with us, that wants to have the slide. I'll send it across to you. Okay. And before I go, I put my hand up to recognize one of my superiors here. He's on the call. If it's okay to do that.
Yes.
Mr. Latif Adeyemi.
Yeah, that's really good.
Yeah, sent me a text. So he was my senior when I was in nursing school years ago. He's been a mentor too. So, sir, glad to have you. Nice to see you too.
That's really good. Thank you so much. As you said, it should be problem solving and not laying the blame game, because leaders tend to play the blame game more, and people get discouraged from reporting incidents, reporting errors, and things like that. So thank you so much for that clarification. And just to mention this, the senior colleague that you mentioned just now is the current chairperson of the founding chapter of TORG. That's TORG Nigeria chapter. So is the chairman of TORG Nigeria chapter. And is hosting us in Nigeria at the upcoming conference. Yeah, he's the one organizing that.
That's good.
So that's really good. Thank you so much for that. And at this junction, I really want to say thank you to everyone for connecting from all over the world. A million thanks to the TORG Education and Training Committee for facilitating and organizing the session. Thank you to everyone who connected. I know there are 12 countries represented. Some people still registered very late, so I may not be able to call out all the countries, but I still want to say thank you to everyone. The next webinar, global one, is in 2 weeks. I'm just showing that on the screen. There's chapter webinar sessions coming up. I think the Pakistan chapter will be doing something on robotics, and Rwanda chapter will be doing something on clinical audits. But the global one would be coming up in another 2 weeks. It's an hour before 6. That's 5 o'clock BST, IST, and GMT +1. That's coming from Ethiopia. It's going to be advancing pediatric cardiac care, the role of electrocardiography in diagnosing and managing pediatric heart conditions. It's something related to cardiac surgery on pediatrics, ECGs, and echo. He's an echo specialist, and he would be addressing us in another 2 weeks. So as I said, thank you to everyone for connecting. This session is recorded. We're going to share a replay over the next few days. And when the replay is shared, that's the presentation is going to be on the same link, and everyone would be able to access the presentation as well on the replay link. So thank you to everyone for connecting. I want to say good morning, good afternoon, and good night depending on your time zones. And have a nice day ahead.
Thank you so
Bye.
much.
Thank
Bye-bye.
you so much, sir. Bye. Bye. Bye.